Hello and welcome to this special edition of Euronews Now. Now, you've been sending us in your questions about COVID-19, which we'll be putting to the experts over the next half hour.
And that's where I come in. I'll be monitoring all our social media feeds, so do send in your questions.
And we've received a lot of queries already in what's actually been a very busy week in terms of coronavirus developments. Across Europe, COVID-19 containment measures are gradually lifting, but in many hard-hit countries, weeks of lockdown remain. Parts of France have seen a spike in public unrest, with violence and vandalism erupting in major cities. Elsewhere, governments and organisations facing accusations that they didn't act quickly enough to stop the virus.
I think we declared the emergency at the right time, and when the world had enough time to respond.
We were slow into lockdown, slow on testing, slow on protective equipment, and now slow to take up these offers from British firms.
I don't accept his premise that we've been slow. We have been guided by the scientific advice.
And in European care homes, a disaster in the making as deaths continue to mount.
According to estimates from countries in the European region, up to half of those who have died from COVID-19 were resident in long-term care facilities. This is an unimaginable human tragedy.
But public health and safety is not the only concern for world leaders. The crisis continues to take its toll on financial markets, with the value of oil plunging below zero for the first time in history.
The scale of oversupply, demand's fallen so quickly, the scale of the oversupply we've been left with over the last month, 6 weeks, has never been seen before.
The EU is still working on a financial lifeline to offer its worst-hit member states. On Thursday, the bloc took a step forward.
We endorsed the agreement on 3 important safety nets for workers, businesses and sovereigns, amounting to a package worth €540 billion.
But long-term relief remains up for debate.
There are disagreements. There are states with very strong positions whose political constraints justify them.
In the midst of so much uncertainty, medical experts are working towards a vaccine, and in the UK, promising signs that one could be on its way.
I can announce that the vaccine from the Oxford project will be trialled in people from this Thursday.
But human trials are still at an early stage, and even the experts remain unsure of when a finalised vaccine will be available and who will get it first. Well, you've been asking questions. We're going to try to get you answers. For the next half hour, we'll be speaking with 2 experts who've been working day and night to understand the pandemic. And I'm joined by Dr. Müge Çevik, who is an infection and global health researcher at the University of St Andrews. She joins us from Edinburgh. We also have Cristina Scaduto from the Harvard School of Public Health. She's an expert in data analytics and infectious disease. Hello to you both. Thanks so much for joining us on the programme. Now, for most of us who have been in lockdown, at times it feels like we've been running without moving. You guys have been very busy. As we were just saying, it's been a busy week when it comes to coronavirus developments. But first of all, could you just tell us, in terms of what we have learned so far, and briefly, what are the biggest breakthroughs? And I'll begin with you, Müge.
Many thanks, first of all, for inviting me and being careful to include women in this discussion. I'm very happy to be joining my colleague Cristina, who's also involved in an organization called Women in Global Health, which advocates for better representation of women experts in the media, so that we're all contributing to a robust conversation. I think when we look at the biggest breakthroughs, over the last 3 months, we've seen extraordinary scientific progress. We've seen the virus genome being shared with the world immediately, and within 18 days, we had the first diagnostic test. Since then, we now know how the virus basically attacks the body, And now we have much better diagnostic tests, trying to understand the pathogenesis. And over the last 3 months, we had extraordinary data, more than 3,000 articles from across the world, trying to understand the clinical progress of this new infection. So I'm quite optimistic about where we are at from a scientific perspective.
Okay, and Christina, then from your perspective, do you share Müge's optimism? What have been the breakthroughs from your area of expertise?
Absolutely. I think that this is an unprecedented time for everybody, but in terms of scientific knowledge and the data that's been collected so rapidly within the last few months, it's something that we've never seen before. If this pandemic had happened even 20 years ago, 30 years ago, I don't think that we would have the type of access of information and data that we are able to see today.
And it's interesting you say that we are able to access a lot of data, and that comes for all of us because we've almost become kind of couch experts when it comes to COVID-19. So we receive a lot of very specific questions. And I have a question here for you, Müge, and this is about treatments. And it's a double question. And this is from someone by the name of Damjanovic on Instagram and Bolaj Sani. And Damjanovic asks, what about the treatments remdesivir and hydroxychloroquine? Bolaj Sani asks about ivermectin. Now, in terms of you, you're treating patients on the front line. What have you seen in terms of those treatments available and what's giving you hope?
I think it's, first of all, important to emphasize that at present, there are no approved antivirals or treatment for COVID. There are several antivirals that has shown promise, mainly in lab data. And also we've seen some promising evidence in animal models. And there are actually quite a lot of clinical trials currently in progress. So it's, I think, currently early to comment on this new antivirals. We need to see the randomized controlled trial data. And most of the patients we're treating on a daily basis, we provide supportive care, which includes oxygen, fluids, and sometimes antibiotics if they have bacterial infection. And when they're in intensive care unit, they can be given supportive care and additional antibiotics, for example. But at the moment, I think it's quite early to comment on these new treatments.
Christina, I can see you nodding your head there, but this is also to some respects where you come in, because you were saying there's an avalanche of data come in, but this has to be processed. Now, is there a centralized method in some respects to crunch all this information, for example, that we are receiving from the medical side so that is used effectively to help pinpoint treatments, vaccines, a whole host of issues that come into play when we think of COVID-19?
Yeah, that's a great question. I would add the caveat that, yes, we are seeing lots of data, but there are also existing challenges of incomplete data, and that it doesn't tell a full story. So the way that we collect this information can be different from country to country. Data and science is often viewed as a universal language, and it can be viewed as an objective measure, but there are issues with data biases and data quality. And a lot of it really is stemming from not just testing enough people. We really, I think, this has been said over and over again, but we truly just do not know the number of people who have this virus. And without more information, we really cannot, data is like a flashlight in the dark. It really allows us to know where we need to develop our programs at the right place, at the right time, doing the right thing. But healthcare data is notorious for being complex. It's notorious for being really all over the place. And, for us to ensure that we're collecting this data, we also need to make sure that the quality of this data is optimal.
Okay, well, health data is very complex, and that is something we really are beginning to understand, and quality is extremely important. Now, another issue that has come up time and time again when we think about COVID-19 are tracing apps. Now, that would help us understand the spread of the pandemic and contain it. But there are issues, of course, in Europe in terms of privacy, which don't necessarily come into play if you think of countries like South Korea, but also Singapore. So there's a lot to understand here, and Shauna in the Cube has been following all of this.
Well, my phone doesn't have a contact tracing app on it yet, but it might in the days and weeks ahead. And that's because this is becoming a much broader conversation on the European continent as to whether these apps could help curb the spread of COVID-19. And we do know that, for example, here in Europe, we had the EU Commissioner for the Internal Market speaking with the Apple CEO, Tim Cook, this week. He said that these apps must be fully anonymised, voluntary, transparent, temporary, secured. These are just some of the ethical questions that are at play here. But how will these apps work in practice? Well, we do know that Google have teamed up with Apple, and they're going to make sure that these apps are operational. They're not creating the apps, but they are creating the system that will allow them to operate. Google released this sheet showing how they will work, and we do know that Bluetooth will be central in all of this, Bluetooth technology. So, for example, we have two people, Alice and Bob, sitting on a bench having a conversation. Bob then becomes positively diagnosed with COVID-19. He enters that into the app. The phones, while they were on this bench, they had to be on this bench for around 15 minutes. That's a caveat. They exchanged anonymised beacons. We do know then now Bob has consent, he gives consent for the phone to upload that data into a cloud, showing the places that he has been, showing the people, the data exchanges between the people he has met. Alice then continues her day unaware that she's potentially been near somebody who was contagious. She then gets an anonymised notification that she was in contact with someone. Certainly this is how it's going to work. It will be different from some of the other apps we've been seeing globally. Let's just take a listen.
So it depends on the app and the type of technology that they use. If you look at somewhere like China, they use the geolocation tracking that's enabled on your phone. Iran uses your actual phone network to track your mobile device. Whereas the apps that we're seeing developing in Europe and Western countries, they are based on Bluetooth technology. So it's more privacy respecting, and it doesn't share as much information about you.
The debate that's being had this week is to how these apps will operate in practice. That's another debate, whether they will be centralised or decentralised. So let's just break this down. Centralised tracing apps mean that data is stored outside of the phone. They're stored on a separate server. The advantage to this will be that they could be shared, the data, with health authorities. They can then verify that information that was uploaded onto the app, for example, whether somebody did actually have COVID-19. However, privacy is within all of this. Decentralised apps mean that the data is stored within the phone, more privacy preserving. However, they'll have to rely on public trust, meaning that the data won't be stored in an external server. China, for example, all of these apps are extremely centralised. And I spoke to Sam Woodhams, who has been tracking all of these developments, and he says this is key.
The speed in which things are changing, and that means that a lot of these measures aren't facing any public or political scrutiny. So it's important that we document the measures so that we ensure that after the pandemic is over, these measures are also repealed.
But let's just put how they will operate aside for one moment and look at the ethical questions to all of this, because this is certainly an ethical topic. Now I'm going to speak now to Professor of Bioethics here, Effie Vienna. Thank you so much for speaking to us this afternoon. So what are the ethical considerations here? Where is that line between privacy and public health?
Thank you. Thank you for having me. So as you mentioned already, one of the major concerns we have is what's happening to our privacy when all this data are collected somewhere, either centralized or decentralized. We know that in public health emergencies, of course, there is ethical justification to constrain liberties and to infringe on privacy. But the question with the digital system is that we have suddenly
many more actors in this ecosystem. We have the phones, we have those who operate the systems, we have the public health sector. So we have different players that may have, when privacy is infringed, may be infringed at multiple layers. So this is, I think, a central concern. Another concern that is of ethical nature, and it goes beyond privacy, is actually the fact that until now, we don't know the efficacy of these systems. We hypothesize that if Alice and Bob are sitting, as you pointed out, in a bench and proximity is established, then we'll know something about them and then we'll follow up, and hopefully that will help us break the transmission chain. But we have never tested that. We have not validated those systems. We have not used them at scale. So essentially, the efficacy is still, for that efficacy, we have limited evidence. And what we're trying to tell people, what we will tell people is, on the basis of limited evidence, we are going to take a leap of faith and infringe privacy maybe, or other liberties. So that's, I think, another issue that it's quite central at the moment in this debate.
But it's not just about privacy, is there? What are the other ethical questions to be had here?
One was also on the list of the tweet that you showed earlier, which is about voluntariness. We are assuming that all these apps will be voluntary in terms of downloading them. Now, once you download an app, let's say on a voluntary basis, does this voluntariness continue? Do you voluntarily upload your confirmed positive COVID status, or if you are notified that you were exposed and at risk maybe of having been infected, are you continuing to voluntarily call up a helpline or take the measures that you're going to be told to take? For example, quarantine, go test, or whatever it is that the protocol will direct you to do. Voluntariness, therefore, when we're speaking of voluntariness, I think right now we're speaking of voluntariness as far as downloading the app is concerned. And my own concern is we give maybe not the full impression of how voluntary the entire system is going to be. And how voluntary it's going to be is probably going to have an effect on how efficacious it will be as a system of tracing in order to, again, break the chain of transmission. And here, I think the debate we're having it's very important. It has to be. We're having the debate right now, probably between academics or amongst academics and technology people. I think we'll have to have it in a more broader sense with more stakeholders, because that will be quite critical.
Okay, well, some important questions raised there, because it's not only a question of privacy, ethics, public health, of course, as we were just hearing there. It's also a question of scale. Now, we received a video question from someone called Anna Martinenko. Now, I'd just like to play this, and then after that, I'll come back to you, Christina.
How likely is it that 60 to 70% of the population in any given country will actually download one of these apps? What does it mean if we do not reach this majority? And are there any regulatory frameworks being considered to encourage the download?
Okay, Christina, that's a great question. So what is the scale required for these apps to work?
Yeah, that's a great question. So at a minimum, we're looking at about 60% of users to download and use this app. And we have seen with other countries, in Asia specifically, in places like Singapore and China, where there are existing technological apps with contact tracing. But I think what's really challenging is that in these contexts, you can't really compare apples and oranges. There are a lot of cultural differences between some of these countries. And if we were to implement this in places like the US or Europe, where in Asia, we have seen technologies like this before. In Singapore, it is required by people. The government is really taking ownership of using these contact tracing apps. But it's definitely a two-way street. There needs to be leadership and buy-in from the government and leadership, but there also needs to be buy-in from its citizens. And, you know, what I think is that in places like the US, even if we have protocols and frameworks and policy ideas from the government, it might be a little bit more difficult to be implemented. Thinking about it publicly, the U.S. is a very diverse place. We're talking about people from all over the world. It's also a very large country. So there are many cultural differences that we have to consider when we're thinking about developing these apps. And it's not just about the technology, but we really have to consider the end user and put the patients at first.
Okay, yeah, the patients always need to be central to this. And you were just talking about leadership and the US. And another big issue that's really been highlighted this week is the question of misinformation, particularly when it comes to treatments. Now, let's listen to this soundbite now from Donald Trump, the US president.
Supposing we hit the body with a tremendous, whether it's ultraviolet or just very powerful light, and I think you said that hasn't been checked, but you're going to test it. And then I said, supposing you brought the light inside the body, which you can do either through the skin or in some other way. And I think you said you're going to test that too. Sounds interesting. Right, and then I see the disinfectant where it knocks it out in a minute, 1 minute. And is there a way we can do something like that by injection inside or almost a cleaning? Because you see it gets on the lungs and it does a tremendous number in the lungs. So it'd be interesting to check that.
Well, Muge, I could see you shaking your head as you're listening to that. So there's been kind of global outrage to Donald Trump's comments. How dangerous is it, do you think, when a world leader steps into a public health debate and talks about possible treatments? And is there any validity at all to what he's saying?
I mean, I'm extremely worried about this statement. We need to be clear that under no circumstance disinfectant products should be administered into the body through ingestion or injection or any other route. Disinfectant and hygiene products should only be used as intended, only externally, to clean surfaces and hands. These are really toxic substances and can be corrosive when ingested. It can burn the respiratory tract and digestive tract. So I think this type of rapid and unregulated spread of misleading or false information is very dangerous. First of all, these can cause direct harm. As we know, almost 300 people have been killed in Iran by ingesting methanol and bleach. And on the other hand, this false information also generates confusion and it obscures the delivery of key messages and can cause public reluctance to adopt well-founded practices like social distancing and hand hygiene.
And Christina, now in terms of your line of work, I can only imagine that when it comes to trying to aggregate information, misinformation must create a huge stumbling block for you.
Absolutely. And I think that is one of the challenges that we run into with our data, with our biases in our data. And when there is misinformation, if we're coming up with algorithms and models to predict the likelihood of flattening the curve, we really have to consider public and social measures on people's behavior. And people's behavior is very difficult to predict. And it's also hard to change people's behavior. So I think the big question now is that, really bridging this gap between what we know and what we do, because we may have evidence-based and we have data to support our decision-making and develop strategies, public health strategies. But at the end of the day, it's really up to the people and people's behavior to make progress on this pandemic.
Yeah, and just to end now, I'd like to have a question to both of you, because when we speak about data now, as journalists, data that we use a lot is from Johns Hopkins University. And if we look at that, we are getting close to 2 million confirmed cases of COVID-19 worldwide, 200,000 deaths. But also an important figure is also we're reaching 3 million cases, 3 million confirmed cases. But when we look at the recovery figure, we're also looking at near 800,000 cases of recovery. So would you say that whereas sometimes we look at the cases, we should also be focusing also on the level of recovery, because that might be the brighter side to this story of coronavirus that we are all living through today. And I'd like to begin with you, Christina, sorry.
Yeah, that's a great point. But I think, as you mentioned, at the aggregate level, we are seeing many people who are recovering. We are, in some of the countries, the curve is beginning to flat out. But we really need to disaggregate this data and look at the data by gender, by different demographic groups, by age and sex. And in places like the United States, where again it's very diverse, we are seeing differences in outcomes on race and people's economic status and the neighborhoods that they live in. Your zip code can dictate what your life expectancies are in some of these major cities. In a place like Boston, we have this public transportation called the T, and depending on, even just 3 or 4 stops away, it's a life expectancy difference of 15 to 20 years. So even if we are seeing at an aggregate level high levels of recovery, what does this say about the African American community in the United States, would have been predominantly hit by this virus the hardest with the highest mortality rates? We really need to drill down on the data, disaggregate the data, and look at it as closely as we can as possible.
Okay, finally, Muge, you are looking at this data, basically one individual at a time. Now, if you look at the rate of recovery from COVID-19, would you say that these figures I've just been talking about from Johns Hopkins do tell the true story of the coronavirus?
I guess we need to understand most of this data is coming from patients who are unwell and presented to hospital. So most of the countries at the moment are not necessarily doing community testing and widespread testing. So we don't actually know how many patients are out there who may have mild illness and recover without needing hospital care. So there are many different academic and commercial tests to test for antibodies are currently in development. So these tests could check whether someone had been exposed to the infection. So this can tell us how widespread the infection is, and can also tell us how many patients recover without needing hospital care. So I think once we have this information, we'll have a better understanding of the recovery rate. But when we look at for example, intensive care outcomes, some of them are quite disappointing. But still, we don't know how many patients are at the end discharged from ICU. As Christina said, it's not very clear at the moment, the age distribution, comorbidities, background. These are, we need to look into detail of these aggregate data.
Okay, so there's still an awful lot to learn when it comes to the coronavirus. I want to thank you both so much for joining us on the program. And that is, of course, Muge Cevic, an infectious and global health researcher at the University of St. Andrews, and Christina Scaduto from the Harvard School of Public Health. Well, thank you so much for joining us on this program, and do keep sending us your questions.